Hi, good morning everybody. Sorry for keeping you all a bit late. I probably have bitten off slightly more than I can chew at the moment by being on call at the same time as trying to do this, but now I'll give my phone to Alicia so she can cope with it all. I don't know if I need to chat. Well, I'm not sure. Can you hear me if I'm speaking at this distance from the microphone? I tend to wander around a bit, so yeah, if I'm getting a bit difficult to understand, just tell me and I'll try and breathe and elaborate where I'm standing. So thank you for inviting me to speak today, Alicia, and it's nice to be speaking with my colleagues as well. It's, hello, there's one of them at least, okay. So, yeah, I am a neurologist. I work at John Hunter, and I also have for a long time worked at the Mater Hospital, where a lot of people with brain cancer receive most of their care. So Alicia asked me to talk with you guys about things that she felt are very common questions that people want to ask about what a neurologist does. For people, actually, hello, my friends are there as well, Chris and Michelle. Yeah, so what a neurologist does as part of the journey for somebody who has brain cancer. So I'll try to do that today, but if you have burning questions or I'm making no sense, please interrupt me and ask, because that's the point of having talks like this. I was trying to find really funny stuff, and maybe I think this is funny, but nobody else does. So neurologists have a lot of nerves, so they're nerves, right? Get it? And I haven't even put down the place that I got that from Google, but that's my new favourite slide. So now, this is a multi-choice question for you. Concentrate, because it's a very difficult one to get right. A neurologist is super intelligent. Only one of these is right, by the way. Hilariously funny. Extremely attractive. Or all of the above. Now there are 3 wrong answers, guys, so come on, what do you think? Come on. See, you're all so... Now, here is a picture of a neurologist and a picture of a neurosurgeon. And I told the neurosurgeon that they wouldn't have been able to tell us apart had I just stuck his picture up without doctoring it a bit. So there you go. He and I are actually involved in a disagreement right now, which is why I was on the phone trying to figure out what to do for something. Okay, so a neurologist specialises in the diagnosis and the non-surgical treatment of diseases of the nervous system, which include strokes, inflammatory diseases of the nervous system, infections, and so on, and may diagnose a brain cancer. So the first point that somebody with brain cancer might ever meet a neurologist is when they're in hospital because they've had a seizure or some symptoms that have meant they have to be admitted to hospital, and scans may show that there's a brain cancer present. Then after that, for many people, a neurologist becomes slightly irrelevant, like that doctor that I met once who I don't remember their name and who cares kind of thing. And that's because a neurosurgeon and doctors who treat cancer very specifically, so radiation oncologists and medical oncologists, are more likely to give the therapy that's needed. However, a neurologist sometimes becomes involved again if somebody has ongoing seizures or is having neurological symptoms as a complication of their treatment, or very troublesome neurological symptoms because of the cancer itself. So, okay, let's talk about the type of symptoms that brain cancer can cause that might mean that somebody has to be admitted to hospital, and I'm sure probably all of you are familiar with these things. So the first thing is that sometimes a brain cancer is diagnosed because somebody had a scan for a reason that's not related to the brain cancer. And so, you know, there are people who have early brain cancers who don't know about them, and they're picked up radiologically. That's a fairly uncommon situation, actually. More common is symptoms which are either related to general effects of the brain cancer on the brain, or very specific local effects of the brain cancer on the area of the brain that the cancer involves. So The very general effects include the ones I've circled here. So people will be familiar with headache, nausea, maybe confusion or personality and thinking changes, maybe problems with sleep or drowsiness. All these things are related often to high pressure inside the skull. So your skull is a box. It's a hard box. It can't expand except for when we're babies, and the reasons that babies are born with a skull that can expand and contract is basically because it has to contract as the baby comes out of the birth canal and then expand as the brain grows very rapidly in the first months of life. So by the time we're a few years old, our skull is a closed box and it stays like that for the rest of our life. So any additional new tissue in there is just going to increase the pressure. It's not going to make the skull expand. So the symptoms that I've circled there are symptoms of high pressure inside the skull. How does a brain cancer cause high pressure? So here's a picture I grabbed from the internet of a fairly large brain tumour surrounded by some what we call edema, which means increased fluid or swelling there in the front part of the brain. So no, you can't see a pointer from the computer, but you can see on the graphic on the left of the slide, up the top, which is the front of the brain, there's a big thing that's whiter than the surrounding tissue. That's the brain tumour, and you can see it's kind of squishing things. You can see the difference between that and the slide on the right, which is a normal brain without a tumour. You can see there's more black wiggly stuff around the edges of the brain. That's space that's supposed to be there. So comparing that normal brain to the one on the left-hand side where there's a tumour, all those spaces, those wiggly black bits, have disappeared because they're all getting squashed by the tumour. So that's one way that a tumour can cause high pressure, just by being big. The other way a tumour can cause high pressure is by blocking the flow of the normal fluid that is supposed to be inside and around the brain. That fluid is called cerebrospinal fluid, or CSF. When there is too much CSF inside the skull, it's called hydrocephalus. Hydro is water and cephalus is brain, so water on the brain. So a brain tumour can cause water on the brain, and that can look like the picture that I've got on the next slide. This slide I put here just to show you that in normal circumstances, CSF circulates around the brain. So it comes from structures inside the brain, it goes down through little canals and things to circulate around the outside of the brain where it's absorbed back into the veins. That's what's supposed to happen, but if you have a big tumour, or in this case, this is a cyst actually, so this is a great big thing filled up with some kind of a fluid, it can squash those channels where the water usually goes, the CSF usually goes, and what ends up happening is back pressure, which then blows up these structures inside the brain. So this is a picture of hydrocephalus. Brain tumours can cause hydrocephalus as well. So it's another way that brain tumours can cause high pressure in the brain, which accounts for symptoms like headache and nausea, confusion, and sometimes sleep problems. So you may have heard of some of these terms that I'm using, hydrocephalus in particular. The other symptoms of brain cancer are what we call focal symptoms, and that really means that it depends where the cancer is in the brain, what structures are affected, and as we all know, each part of the brain has different specific roles to play in maintaining our normal functions. So here's a picture of functions of parts of the brain while people are at work. So I don't know if you can read all of this, but according to this graphic, there's a large part of the deep part of our brain occupied with stimulant medications. And then there's bits of our brains associated with alcohol, so sedative medications, sleeping, winning the lottery, and singing silly songs, and chocolates there as well, and social media. So, you know, that's obviously silly, but, you know, the point is each different part of the brain has a different role to play. So if you think about that in a more kind of boring medical school kind of way, each part of the brain has its own special functions to play. So there's a lot on that slide, and I'm not intending to read it all to you, but you know, the big parts of the brain at the front are largely involved in making us the person that we are, how organised we are, our personalities, our emotions, and so on. Going backwards from there, behind there is the control, the conscious control of our movements, our ability to perceive sensations, and then again more intangible things about how we know where we are in space and so on. That's the green bit. And then the blue bit at the back is largely to do with vision, while the yellow wiggly bit on the side is to do with our language abilities, ability to speak and interpret language, to remember, things like that. So there's a lot of information there, but just to say each part of the brain has its own special role to play. So you can imagine if you put a lesion, a tumour, a cancer, in the pink bit at the front, you might see somebody's personality change. If you put a tumour in the blue bit at the back, someone's vision might change and their personality might be unaffected. Okay, so that's symptoms of brain cancer. A very common focal symptom of brain cancer, which is not to do with a loss of function, which is what those things I was talking to you about before, loss of vision, loss of movement, change in personality. There's another type of symptom which is a seizure, and that's actually sort of, if you think about it, a gain of function. For a short period of time, your brain's doing more than it should usually. So maybe I should take a step back and just say seizures in brain cancer are extremely common, and they are the commonest reason why somebody would come to my clinic, because they have difficult seizures that are not responding to treatment. Depends what type of brain cancer someone has, how likely they are to experience a cancer at any point during their journey through brain cancer. But some people, there's no way out of it. 100% they will have a seizure. Other people may never have a seizure. For some people it may be the first symptom. For other people they may develop later on. So what is a seizure? As I said, a seizure is a temporary disturbance where the brain does more than it should be doing. And the way we conceptualise that is that it's a burst of uncontrolled electrical activity between brain cells. So instead of just, hanging out together, sometimes having a bit of a chat between one brain cell and another, what happens is all the brain cells start shouting at each other all at once. Way too much communication, way too much electrical activity, and everything goes crazy. So an example of a seizure which you might all be familiar with is extra movement, shaking. So somebody could have a focal seizure involving their arm, where their arm would go from being perfectly well under their control to starting to jitter and shake and then become more and more shaky, and sometimes that abnormal movement can spread, say from the hand, up the arm, into the body, into the face, down the leg and so on. So that's due to abnormal extra electrical activity spreading throughout the brain. That's just one example of a seizure that involves movement. Seizures can also cause changes in vision, so people might experience that as jagged lines or strange visual experiences, seeing things that aren't there. They can also cause changes in sensation, so people might experience a seizure as funny feelings in a part of their body. Sometimes they may not be very physically evident, and they may cause a change in somebody's ability to perceive the world. So somebody might feel like they're in a fog, underwater, somehow out of touch with reality. That can be an experience of a seizure too. So just like there are so many parts of the brain with different functions, there are so many types of seizures. There are just many experiences of seizure, and to some extent I would have to say I hear fairly frequently a news story of a seizure that nobody's ever told me before, and that's probably related to exactly where in the person's brain the seizure is starting from. I've been talking largely about focal onset seizures. That means seizures starting in one part of the brain. You can see on the left side I've got a picture of a brain. This time the temporal lobe, the bit that was yellow before, is now green, and there's some jaggedy lines indicating abnormal electrical activity, a seizure coming from that part of the brain. A seizure can also be generalised. That means the whole brain goes for it at the same time. So focal onset seizures, generalised onset seizures. And because, I guess, doctors like categorising things, we have this way of organising our thinking about seizures to include whether they're focal or generalised, whether somebody's aware or not aware, not fully conscious during a seizure, and whether somebody has normal movements or abnormal movements during a seizure. And these things do have implications for what people can do during a seizure, not only in terms of whether they can communicate or walk or move, but also whether or not they can, for example, control a motor vehicle or surf or climb a tree holding a chainsaw while they're having a seizure. And so these are the sort of things that run through a neurologist's mind when they're talking with somebody who's experiencing seizures in terms of what should I advise this person not to do if I think they're at risk of this type of seizure. Not that I've ever actually had anybody have a seizure up a tree with a chainsaw, but I guess it's theoretically possible and would probably not be good. Okay, so the thing is, some people with a brain tumour, a brain lesion, have a lesion in one part of their brain. So therefore, they would be having focal onset seizures. The tumour would cause the seizure arising from one part of the brain. But some people have such a short period from the symptoms starting just in one area of their body, one part of their nervous system, to the symptoms spreading throughout their nervous system that they seem to just have generalised seizures. That's actually fairly common. So brain cancers can cause generalised seizures, and that would be where somebody becomes unconscious and usually their whole body would be involved in the abnormal movements. I've already mentioned a bit the risks associated with seizures, but it's really important to think about this a bit together, because not only is a seizure very difficult for the person who experiences the seizure, so in this instance somebody who has a brain cancer who does experience a seizure, but a seizure is also very difficult for the people around them, and that's because of not only the awareness that something suddenly has gone wrong for my loved one or my friend or the person I don't know who's next to me in the bank queue, but also because you're worried about, my gosh, could they hurt themselves? What am I supposed to do now? Should I call the ambulance? Should I pull their tongue out of their mouth? There's all this sort of horrible fear that goes along with a seizure. So I just wanted to say to you really what the risks are from seizures to help you kind of think about this in a fairly a fairly rational way, I suppose. So most seizures stop by themselves, but without anybody doing anything. So to reassure you, that's a good thing. The ways that people can become injured or harmed during a seizure are particularly if somebody falls over. So you can imagine if somebody goes from where I am with my silly high heels, if I suddenly crash to the ground because I was having a seizure, it's a fair way down to there and the floor's hard. So I can injure my head or my neck in that seizure. So a fall complicating a seizure is generally to be avoided, and that's the reason why people are generally advised to sit or lie down if they're aware a seizure's starting. The other major risk is if somebody blocks their airway during a seizure. So people, I mentioned pulling someone's tongue out of their mouth earlier, and actually that's a fairly common thing that people try to do with all good intentions, because people often don't breathe properly. They're very obviously not breathing properly during a seizure, and so people around them will think, my gosh, they're about to choke, I've got to open up their airway. The bottom line there is, usually people's teeth are so tightly clenched together that you really can't get in there to pull their tongue out of their airway anyway. So the most important thing to do is to put the person in the coma position. So I've actually got a picture of the coma position on the next slide to show you, and most of you are probably already aware of that terminology, coma position. So I preempted myself this slide by saying this is why people with epilepsy should be cautious when climbing in water or using power tools. The one thing I didn't mention is the reason why people fuss if people with epilepsy have a bath is that it is possible to drown in very little water. So again, I always think it's a bit much to tell people not to have a bath. That's like, you know, one of the top 5 best experiences of being alive, right? So, not wanting to give too much away about myself there, but maybe just leave the door open and tell someone you're in the bath kind of thing so that people can monitor what's going on for you. The other situation where we've got an emergency is if a seizure, a generalised seizure, where someone goes unconscious and their whole body is going for it, lasting more than a few minutes is a medical emergency, and that's because you're basically running a marathon while not breathing if you're having a seizure like that. So it's a very, very demanding thing for your heart to have to deal with in particular, but the whole of your body. So if a seizure like that goes on for any more than a minute or two, it's time to call the ambulance for that reason. So this is Seizure First Aid recommendations from Epilepsy Australia, I think. I don't know if I've made that big enough for you to read, but I will just read through that for you. The recommendations for from Epilepsy Australia for if someone has a seizure is that you should time the seizure. So I think that timing a seizure is hard to do for most people because it's horrible. You're freaking out. You're trying to ring the ambulance. You're trying to get the person in the coma position. So don't beat yourself up if you've got to put the timer on. It's not the end of the world. But ideally, we would know how long the seizure's been going for. The second thing is to protect the person from injury. So obviously, if they've got a chainsaw, stop the chainsaw if you can and take it away from them. But the big message is put the person into the coma position. So as it shows in the graphic here, what you need to do is to roll the person gently onto their side and with their upper leg curled over their lower leg to help them to stay in that position. And the reason for that is all about trying to prevent anything going backwards into their airway and blocking it off. And that would include their tongue or vomit or their dentures. So that rather than trying to put your hand in their mouth and pull something out, that's what you need to do, put them in the coma position. The next things are to do with the fact that often when people recover from a seizure, they're not with it. They're not their normal self. They might be combative. They might be like, who the hell are you and get me out of here. Or they might be tearful or very anxious. So reassure the person and try to stay calm yourself. And basically, I just think with a seizure, particularly if you haven't experienced many of them before or looking after somebody who's had one before, I think you need to call an ambulance if you're worried. And if the ambulance gets her and goes, well, they're fine now, well, that's good. But yeah, call the ambulance if you're worried. Then Epilepsy Australia puts on the bottom of their slide, don't try and restrain the person. So that's that situation where somebody's freaking out and saying, what are you doing, why am I here, and trying to throw punches and stuff. Don't try and stop that, because you might just end up, also on the floor if they happen to connect with your head in the right way. But also don't try and feed them or give them anything to drink. And that's not only because they might not be able to swallow properly at the moment, but what happens if they have another seizure in a minute with a sandwich in their mouth or something? Okay. Oh, I'm out of time. Does anyone have any questions about that stuff? No?
Discussion.
At the end? Okay. Okay. So how do we treat seizures in brain cancer? So the first thing to say is, sorry there's a lot on this slide, but the first thing to say is the treatment of the brain cancer is treatment of the seizures as well. So, trying to remove the tumour, or as much of the tumour as can be safely removed, is partly an effort to control seizures, as well as it is an effort initially to figure out exactly what it is and also to get it out of there before it can cause more harm. But the other thing is actually radiation and chemotherapy can reduce how frequently seizures are happening for many people as well, and that is dependent on the type of cancer, exactly how successful that is. Where I come in is when the anticonvulsant medications that the neurosurgeon and the oncologists are initially prescribing for people who have seizures are not really working, or they're causing so many side effects that they're not really worth taking. So the common drugs that we use to try and prevent seizures happening, number one these days is Keppra, levetiracetam, which is also called Keron, Kevtam or Levi. So I think that's probably the commonest prescribed anticonvulsant medication now for brain cancer. A few years ago it was some of these others, but that's the drug. Other options that we use commonly would be sodium valproate, which is also called Epilim Valpro or Valprise, lacosamide, which is also called Vimpat, phenytoin or dilantin, used to be used a lot, it's not used that much at all anymore, for reasons to do with interaction with chemotherapy drugs in particular. And then there's a drug called clonazepam, which is also called Rivotril or Paxman. So I suspect some of these names will be familiar to you. There are more than 20 anticonvulsant drugs available to us in Australia now, but these are the top 5, and it's very rare that we would be using other drugs for people who have brain cancer. The other thing is we do give dexamethasone quite often for people who have brain cancer, and it may help settle down seizures in the short term as well, although it's rarely that useful in the long term. So it's a drug we use short term and we try to get people off it because it does tend to have side effects. Okay, side effects. Problem with all drugs, chemotherapy drugs, drugs given for anxiety, depression, all sorts of drugs, but very common with anticonvulsant drugs. These are probably the commonest across the board with anticonvulsant drugs. Feeling drunk, I think, might be a reasonable description of the way people feel if they're started on epilepsy medication, particularly if the dose is pushed up fairly quickly. But that can be dizziness or headache or a bit of behaviour change, just grogginess, sometimes a bit of trouble walking, a bit of unsteadiness. These are common side effects, and we do our very best to try not to prescribe too high a dose too quickly so that people end up feeling just terrible because of the epilepsy medication, because it's hardly, apart from anything else, people tend not to want to take the drugs if we do that. So the reason why people are often started on smaller dose and built up is partly in an attempt to avoid these types of side effects. Each drug has its own very specific side effects as well, and the role of the doctors who are prescribing the drugs is obviously to watch out for that and try to avoid them causing too many problems. I think the last thing I wanted to talk about was actually the issue of driving, which is just really major problem for people who have neurological issues in particular. It's a life-changing thing, having a brain cancer in so many ways, but one of the big ways is that suddenly you can go overnight from somebody who was completely independent, doing everything you want. If you wanted to go down to Macca's through the drive-through, you just go in your cars. And suddenly people say, no, you can't drive. So for anybody, that's difficult. It's difficult for elderly people who get to the end of the time when they can drive safely as well. But it's very difficult for people who are younger, who are still working and looking after children or whatever life involves. Not being able to drive is devastating sort of a thing to have happen to you on top of the terrible news about the brain cancer. So I just wanted to go through with you the guidelines that medical people are asked to apply, which are provided by the Roads and Maritime Services, just so you know where we're coming from. I have copied what is written in the document that I've got a picture of in the corner, which is called Assessing Fitness to Drive. I feel like this thing is just going further and further down. I hope I'm not too hungry. Yeah, so I have copied the Assessing Fitness to Drive guidelines here, just to show you how wordy they are, but also how kind of careful neurologists and other doctors are asked to be when dealing with disorders of the brain or trying to figure out if somebody can drive safely. And I would have to say that I honestly feel that my capacity, or anybody's capacity, to 100% know how well somebody can drive a car when I'm sitting in an office and they're sitting in a chair next to me in an office, it's a bit limited and it's not always 100% fair assessment. But nonetheless, this is what we have to work with. So the RMS says, safe driving is a demanding task that requires a number of intact neurological functions, including visuospatial perception, insight, judgment, attention, concentration, comprehension, reaction time, memory, sensation, muscle power, coordination and vision. So there's a lot of, these are all the functions of the brain, right? So for me to be able to say, this person's fine, of course they can drive. First I have to be happy that all of that is intact. And it's not always 100% easy for me to say that in an office. The RMS instructs us, impairment of any of these capacities may be caused by neurological disorder and thus affect safe driving ability. Well, that's self-evident, I guess. What the RMS tells us to do is, if we don't think people, if we're worried about these, if we're not worried about any of these things, if we think all that stuff's okay, but the person is in our office for a particular reason, we have to think about the following. So, if somebody's had an operation inside their skull, intracranial surgery, the RMS tells us they should not drive for 6 months if they're driving a private vehicle, if they have a private licence. They should not drive for 12 months for a commercial licence. And that obviously doesn't just mean you can't drive for 6 months. It means you can't drive for 6 months, and at the end of the 6 months, the doctor needs to be happy that you're okay to drive at that point in time, or the 12 months, whichever time frame we're thinking about. For somebody who has a brain tumour, they say conditional private or commercial licence only if no neurological impairments. So that's for somebody who has a brain cancer or a brain tumour but hasn't had an operation. So they don't put a time frame on it at all. They say it's okay if the doctor thinks that you've got all your neurological functions intact. They then say a practical driver assessment may be required, and that's what I was getting at. This idea that I, in my office, can see exactly how well somebody can drive by sitting next to them and getting them to walk up and down my corridor and, do this and move their eyes and stuff. If I'm really not confident enough, I can suggest a practical driver assessment may occur. Practical driver assessments are provided by the RMS. The thing about, and they don't cost, but the thing about those practical driver assessments is you either pass or you fail, that's it. The other type of practical driver assessment is one that is supervised by an occupational therapist. An occupational therapist is quite good and very well trained in looking at all those neurological functions that I was talking about before. So an occupational therapist is much more likely to say, okay, look, I don't think you can drive 100 kilometres safely, but I think you'd be all right in 10 kilometres around your home. Or I think you can only drive during the day, or whatever. So it sounds better, right? The major problem with it is that there's no funding for occupational therapy driving assessments in Australia, but you have to pay for them, basically. And Alicia might know the cheapest one around. In Newcastle at the moment, to my knowledge, it's about $700. That's the cheapest one. So
mine was cheaper than that.
Oh, really? You're prepared to be kind of buy the whole room. Yeah, so $300, that is cheap. Yeah. Okay. This is my last slide. Driving and seizures. For people who have seizures, not being able to drive is really difficult, like it is for anybody who's told they're not allowed to drive. But probably made more difficult by the fact that people who have seizures oftentimes are completely fine, except for the 0.01% of their life when they're having a seizure. So all the rest of the time, they're fine to drive. It's just you can't predict when the seizure is going to happen, and if it happened while they were driving, you've got a problem. So the RMS tells us that for anyone who has had a seizure, the non-driving period is 12 months with no seizures after the first one, except if certain circumstances exist and the doctor says it's okay. So it's 12 months. For commercial licence holders, it's 10 years. And after the 10 years, you have to see the doctor every year. Okay, so, yeah. this is why we have to be the bringers of bad news, because the RMS basically, mandates that we apply these rules. But these rules, this is always difficult, the driving instructions given by medical people, because medical people are there to prioritise your health, your care, your well-being, but at the same time they're telling you something that's really difficult for you to do. So it's hard. So the last thing I put here is just about my practice in advising people about licensing. Basically, if a person has had a seizure, they are legally obliged to notify the RMS that they've had a seizure if they're a licence holder. That's what this document says. The RMS will then request information about the seizure from the treating doctor. The treating doctor will provide that information, but it's up to the RMS. It's not up to the doctor to say the person's right to drive or not. So that I do not sign people's licence and give them their licence back. I tell the RMS I think the situation the person is in is right for them to have their licence back. It's up to the RMS to decide, and that's because the RMS is ultimately responsible, but also that they may know things that I don't about motor vehicle accidents that the person has forgotten, or there may be other information there. So that's how I practice regarding driving. So I think I have gone over time. I'm sorry about that. Hopefully that was sort of instructive and useful information for you, and sorry again for having been late. Thank you very much.